a diagnosis, history, examination, investigations, and treatment. So, presentation. A 16-year-old girl presents with her mother with recurrent history of weight loss and preoccupation with the size of her body. Outline how you will assess and manage her. So your provisional diagnosis for this lady is that she has anorexia nervosa because she's a young girl with recent weight loss and a preoccupation with body size. However, my differentials for her would be bulimia nervosa, avoidant or restrictive food intake disorder, mood or anxiety disorders such as major depression, social phobia, OCD, body dysmorphia, and psychotic disorders. In terms of bulimia nervosa, usually the patients have less weight loss or they're of a normal weight compared to anorexia nervosa patients. Restrictive food intake disorder. These individuals do not fear of gaining weight nor becoming fat. They do not have a disturbance in the way they experience their body shape. They just restrict what they eat. Mood, anxiety, and psychotic disorders. Those who have major depression often lose weight as well, but they don't have any excess fear of becoming fat. They just don't have an appetite, and they don't have any disturbance in the way they look at themselves in terms of their body shape. Social phobia is a fear of eating in public, and if they're always in public, they may lose a lot of weight. OCD with food, body dysmorphia, so a distortion unrelated to a body's shape and size. For example, that they're looking at one particular item, such as their nose is too big or their eyes are too small. And schizophrenia, they often have odd eating behaviors, which can cause them to lose weight. In terms of history, you want to ask about their eating as well as their weight history. Ask about the consequences of losing so much weight. Screen mood, anxiety, and psychotic disorders. Assess their personality history, such as a childhood eating problems, having bullying, and educational achievement. Ask about a past psychiatric history, such as previous eating, mood, or anxiety problems, and do a risk assessment to themselves, to others, suiciding, legal and financial risk, aggression, self-neglect of others, and driving. So in terms of eating and weight history, you want to ask questions such as, what is in your typical day's eating? Is there a calorie limit that needs to be stuck to? Are there foods you avoid? Do you ever binge, use laxative medications that help you bring up food? What do you think about your weight? In terms of asking about consequences of weight loss, this includes, do you have any amenorrhea or infertility, or do you still have your periods? Do you have any constipation, low blood pressure, slow heart rate, sensitivity to cold, protein deficiency myopathy, protein deficiency edema? Obviously, you don't say these in specifically, but you are looking for signs suggestive of malnutrition. You also want to check for their dentition due to vomiting. And it's always the back of the top teeth that get affected because when they vomit, the tongue protects the bottom teeth. Ask about, do you ever seen another specialist and for what reason? What is the impact of the eating restriction on their lives? Ask about predisposing personality traits such as having obsessions. Don't forget to screen for potential mood, anxiety, and psychotic disorders. And ask about their childhood eating problems, any bullying, and educational achievement. In terms of examination, you want to do a mental state examination, an EAT scale, which stands for Eating Attitudes Test, but there are many available, as well as a physical examination, looking at their weight, their blood pressure, their gait, looking for any proximal myopathy, such as which would result in them having difficulty standing up from a chair. Check for any calluses on the dorsal aspect of their knuckles because they've been using it to cause the gag reflex and vomit, and it knocks against the top teeth, and this is known as Russell's sign. And also check for dental hygiene. In terms of investigations, bedside, you want to do an ECG to look for hypokalemic changes, such as flattened T waves. You want to do bloods, full blood count, EUCs, thyroid function tests, because they could have hyperthyroidism, lipids, cortisol, sex hormones, and imaging, DEXA for osteoporosis. In terms of a management, you want to use a multidisciplinary and biopsychosocial approach involving child psychiatrists, psychologists, allied health such as physiotherapists and OT. And if the patient has serious condition, you want to admit them into hospital. You want to have some general measures for all patients, which we'll discuss next, as well as psychotherapies, with the most effective being family-based therapy, known as the Maudsley method. CBT and IPT are also used, but it doesn't have as much evidence. The reason why you would want to admit a patient into hospital is if they've had rapid weight loss, they have electrolyte imbalances, cardiac problems, hypothermia, suicidal ideation or deliberate self-harm, and refusal to engage with treatment and failure of outpatient treatment. And if they refuse to go into hospital for admission, you may warrant the scheduling of them to the MHU 2007 Act. General measures for all patients with anorexia nervosa. You need the patient's acceptance and commitment to the treatment. This is very hard because a lot of them still fear of gaining any weight and they're quite happy being anorexic. Psychoeducation about their disease and what can be done about it, and also the long-term consequences. You need to involve the family and have nutritional rehabilitation and also dietary advice. Just beware of refeeding syndrome. So you give all this great advice, they go home and they start eating like a normal person. This can actually be quite dangerous and they may get this refeeding syndrome. So for patients who have been starving, suddenly loading them with the carbohydrates, just orally or through TPN, it results in a strong insulin response and results in excessive uptake of electrolytes. This results in hypoglycemia, hypophosphatemia, and hypokalemia. This results in altered consciousness, cardiac arrhythmias, and acute heart failure. And so these patients often need an IV drip with these supplementary electrolytes within the drip. In terms of family-based therapy, the Maudsley method is the most popular one and the most effective one, especially in children and adolescents. It involves 15 to 20 sessions with the whole family together. It involves 3 phases. The first phase is the hardest phase. It requires a lot of confrontation because parents are urged to control exactly what the patients are eating and help them gain weight. The patient has absolutely no input into what they want to eat, meal planning, or how the food is prepared. Phase 2 is when the patient has started gaining weight and you want to help the parents to help the child to make more control over their eating again, while the family issues are worked through this phase. And phase 3 is when they can maintain their own weight and normal eating habits. And the aim of phase 3 is to try and minimize remission back into anorexia nervosa by promoting them to develop a positive relationship with their own body, working on perfectionism and low self-esteem, which are often the underlying causes as to why they have anorexia nervosa. Cognitive behavior for anorexia nervosa is the most common because it's quite useful for other diseases, psychiatric diseases. However, unfortunately, the evidence hasn't shown much support for anorexia nervosa. Usually, you again would use the ABC approach, and you want to examine the beliefs about eating and body image, what evidence they have it, and asking about adverse outcomes from this. You want to replace unrealistic thoughts with positive, realistic ones. And you want to reinvent to eat normally without a fear of losing control and becoming overweight. Interpersonal therapy is also used in anorexia nervosa. However, the support and the evidence of the success of this has been less clear compared to the family-based therapy. So this basically focuses on the patient to develop their communication skills so that they can relate better to people who are closest to them. It's believed that psychological distress is often caused by fragmented relationships, and if you mend these can also help with the disease that the patient has. However, because this is not a major risk factor in anorexia nervosa, it may not be useful for some patients. Thank you very much for watching, and I hope that was useful to just get a general overview of the diagnosis,